Good evening, everyone. I'm Robin Toohey, Senior Director Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's Living Well webinar, How to Talk with Your Healthcare Team About What's Best for You. Tonight's program is part of the IMF's Living Well with Myeloma series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. And this is the last IMF webinar in 2017, so we're really glad you're here. I'd like to thank our sponsors for their support of tonight's call: Amgen, Celgene, Janssen Oncology, and Takeda Oncology. I now am happy to turn the call over to our wonderful speakers. Beth?
Thank you, Robin. I'm just very humbled at the opportunity to speak with you all tonight about shared decision making for patients and caregivers. I also want to thank our sponsors for their support and the International Myeloma Foundation for their interest in the topic. Charise and I are on the Nurse Leadership Board, and we do find that it's really important to talk to your healthcare team, but it's not easy to figure out how to do so. So that's kind of what we've put together today. I just wanted to start off by a little bit of a review. So multiple myeloma, as most of you are well aware of, is a cancer of the bone marrow plasma cells. These cells crowd out normal bone marrow cells and produce ineffective antibodies or parts of antibodies. One of the important things to consider is, in many patients that have an abnormal protein which is measured in the blood or the urine, does that individual actually need treatment? The International Myeloma Working Group has done lots of research and has very well-defined criteria for who should necessarily receive treatment. So again, when individuals have an abnormal overproduction of one protein, they need to achieve at least 10% or more bony or extramedullary plasmacytoma and achieve a myeloma-defining event. Most of you on this call are well aware of the SLIM CRAB criteria, the CRAB criteria being hypercalcemia, renal insufficiency, anemia, or bone disease from the abnormal protein, but the SLIM that we just added in 2014 adds to that criteria. So the take-home point on this slide is emphasizing that the overproduction of cells may or may not requires somebody to have treatment. Now, if an individual requires treatment, and we'll talk more about that later, there are many balancing acts that need to be achieved when you're balancing these components. The majority of individuals will be divided into one of two groups, either transplant-eligible patients or transplant-ineligible patients. That means whoever meets this criteria that's again set forth by the International Myeloma Working Group would start on any A, B, or C initial therapy and go through a period of consolidation and oftentimes maintenance. I don't want to get into the details of treatment in the context of this call because we're focusing on shared decision making, but the purpose of this slide is to keep in mind that the disease and symptom control is the main goal in the initial part of therapy and oftentimes at relapse, and we also have goals to extend life expectancy and promote quality of life. No matter what stage of myeloma you or your loved one might be in, we need to also keep into consideration what your quality of life and overall goals would be. This slide here I like to call the long and winding road of myeloma diagnosis. For many people, as we just described, there's a watchful waiting period where some people might not need treatment until they achieve this myeloma-defining event. Again, that's when there's an excess paraprotein that's made in the blood or the urine, and at some point the healthcare team decides to recommend treatment. Then you might start on the myeloma pathway. Through a series of remissions and relapses, there are different points in which you might need to make decisions. You can see on the upper left hand of the slide, if you're looking on the slide, relapse for us might be, for example, a critical period. Again, there are times where we need to make decisions that are very, very important in your care, and shared decision making is one of the tools that you might be able to use to make those decisions. This slide emphasizes some of the examples of critical periods, such as starting and stopping myeloma treatment, or supportive treatment. Let's say you have a new bone lesion and you're experiencing pain from that lesion. Would you need radiation? So how do you discuss that with your healthcare team or not? Blood transfusions. Do you want to take blood transfusions? Transplant or not? I can go on this slide and read these to you, but the take-home point is really to determine, are you in remission or relapsing, and how do we make these decisions? If you're looking at the slides, you can also see these little decision bubbles. I like to use this example because this is exactly why we as healthcare providers will make recommendations. In general, we take the data from clinical experience, the data from clinical trials, and patient preference to then achieve the treatment decision that may or may not be right for you. So to treat or not to treat, that is the question, and with what? So, as we've discussed, there are many different periods in your healthcare journey that you might need to make decisions. Some of the considerations you might think about would be options with other healthcare providers. Let's say you have a primary care provider that you feel very comfortable with. Perhaps you can gather their opinion. Sometimes you want to just review the current results of clinical trials. We have so many new agents, 15 of them FDA approved since the year 2000. And so it's really important to know that information when you're trying to balance what's right for you. Is it more important to have a complete remission, or is it more important to be able to take your kids to dance practice or whatever you might find that's important to you, or even working? So in my daily day-to-day practice, I like to ask people to write down what's important to them. I also like to further ask them to talk to their spouse, caregiver, or loved one, or their other members of their healthcare team. Charise, how do you help patients find out what's most important to them and involve them in your decision-making process?
Yeah, thank you, Beth. I think it's important to start from the first visit, with the patient knowing that they are part of the decision-making. It's up to us to give them our best expert advice because myeloma is what we do, but you really have to bring the patient and the caregiver in. And, part of that is establishing that relationship. This is, a disease, again, with all these treatments, you're going to be spending a lot of time with this healthcare team. And so it's really important. I think, this is a time commitment. We can be rushed in our visits, and I think it's really important to establish that relationship from the start. So, excuse me, as we think about the evolution of healthcare, right? In the old days, you had a healthcare provider that more told you what you needed to do. But we've really gotten away from that paternalistic model, with the emphasis being on a patient-centered focus. And so we really need to bring patients into the decisions, but again, using our expertise to give you that information that you need. So why is this important in myeloma, right? This is the buzz right now. You're hearing this in talks. All of our conversations are going on about this. But again, as Beth said, we've had 15 new drugs since 2000. So there are so many treatment options, and throughout the course of your disease, we're going to have these discussions. And it changes, right? In the upfront setting, most centers have a standard of care, a consensus, I think, in all myeloma that we give an upfront treatment. But we also at that point might from the start talk to you about a clinical trial, or if you're a high-risk MGUS, a clinical trial. So from the start, you may have an option to choose. In that relapse setting, you could have 3 choices at that point, adding to a current therapy or completely switching gears and going to something else. So it lends itself to us having these conversations. We know our patients live longer, and it's really important to discuss goals throughout, and they change over time. So we have to have those ongoing conversations about how goals have changed, what are we trying to accomplish at this point with therapy. So shared decision-making has actually been studied in many different types of cancer, but it's there's little research in myeloma, and you're going to, like I said, continue to hear more about this. So this is a scale that talks about the patterns of decision-making in patients. And this is Degner and Beaton's pattern of decision-making. And what they do, they focus on life decisions in healthcare. And so this is a control preference scale. And you can see it's a small number of patients, 20 patients, but at the top of the scale, that's totally patient-controlled versus the bottom where it's totally provider. And when you look at those 20 patients and what they actually expressed, the second one, I prefer to make the final treatment decision after seriously considering my provider's opinion. That's still more patient-controlled at that point, but if you look at the middle in that yellow, I prefer that my provider and I share responsibility for deciding which treatment is best. It's collaborative, and I think that's where we're going and what we're looking for, and most of the patients said that's what we want as well. A few people, 5% said I prefer my provider to make the final treatment decision, but only after my provider has seriously considered my opinion. So what patients are saying is it's important, we want to be heard, but we want your expertise, right? I mean, obviously, for that decision, nobody on this one wanted to leave all the treatment decisions to their provider. So there are 4 essential elements when we're having this conversation. Obviously, you need to have your healthcare provider and your patient caregiver. We do recommend that you bring somebody with you to discuss, another set of ears, somebody else to write things down. In both parties, share information. And this is how your visit should go, or we hope it's going, right? We take time to build a consensus about the preferred treatment. We're explaining what the options are, what the side effects are, and you're sharing your concerns or previous issues that you've had, and then a mutual agreement is reached between our patient and the healthcare member on that approach to treatment. We know there's also a lot of things to process, and so sometimes that decision isn't going to be made at that time. You might want to go home and actually think about it and get back to us.
Yeah, absolutely, Charise. And I think that it's really important that the healthcare team remembers how important, this is your life. And we are making recommendations for your care, but our recommendations don't mean anything if it negatively affects your quality of life, if it makes you depressed, if it puts burden on people that you don't want to be burdened. This is a lot to think about. Not only do you have the huge cancer diagnosis, but you're actually trying to live and work and function. So we try to present treatment options, discussing the pros and cons, and we really want to ensure that patients and caregivers have an understanding. But again, the shared decision-making process has been around for many, many years in other disease states, in the diabetes groups and in internal medicine type things, cardiovascular. They actually have models of what they recommend. They have decision kits, and that's something that we'd like to get for myeloma patients, and that's what the Nurse Leadership Board will be working on in the next 2 years. But really and truly, it's in its infancy. So what you're looking at on this slide, though, is by this Dr. Kane, when she was introducing the shared decision-making model to the oncology groups. And research has shown that providers do want to hear from patients. So oftentimes what we've seen in the literature is patients are afraid, or they think that we as healthcare providers are going to be upset with them or not want to hear their voice, but that's not the case. Most of the research showed that the providers want you to be happy with your care. We want you to voice your opinion and then arrive in an agreement on the treatment approach. You know why that's so important in our viewpoint, and I know Charise and I have talked about this extensively, is really because we want you to stay on treatment. In 2017, 2018, in this age of myeloma, staying on treatment to suppress abnormal cells, we talked about the myeloma cells, how they become overproduction, how they overproduce protein. We want to suppress that process. And by keeping you on treatment, we're more likely to keep you in remission and achieve a longer lifespan, hopefully, and better quality of life. You're not going to want to stay on a treatment if you don't agree that you need it or if it doesn't work for you. So in this new era of shared decision-making, there are so many benefits, short-term and long-term, for the healthcare providers and for the patients. Most of the large hospitals and even the smaller community centers are putting a lot of emphasis on value-based care. So when we recommend a treatment, is it going to add value in one way or another to that individual's life? Some of the short-term benefits that research has shown is that there's an increased confidence with treatment decisions and a higher satisfaction with treatment decisions. I did a study myself at the Cleveland Clinic, Moffitt Cancer Center, and at Thomas Jefferson, and what I found is I was really looking at side effects and managing side effects, but the number one concern wasn't the side effects, it was, am I on the right treatment? So that just goes to show you how it's a very confusing time in myeloma for not only the patients, but the caregivers and the healthcare providers. At any rate, some more short-term benefits of shared decision-making would be improved self-efficacy. You can get kind of down if you're going through the treatment that you're not wanting to go through or not believing you need it, but it can make you feel more confident if you have a voice. And maybe you didn't need to go through that bone marrow transplant now. Maybe you can delay it until next year or first relapse or when things perk up in your social situation. Other short-term benefits would be, again, the decreased patient caregiver stress and anxiety related to the cancer treatment decisions. If somebody is recommending a donor transplant, that might be right for you, and that might be what the healthcare provider thinks is the best for you, but you still need to have a lot of discussion surrounding that because it's a big decision to have. Long-term outcomes, again, as I mentioned before, treatment adherence has been shown in other disease states and other cancers to be better when you agree that you want to take the treatment and it works better for you. For example, if I have to work full-time, maybe taking pills at home is more convenient to me than going into the cancer center for an intravenous therapy various times per month. So having that conversation is okay. And again, improved treatment outcomes and disease remission is going to be better if you're able to take the therapy. The old C. Everett Koop, the Surgeon General, said drugs don't work if people don't take them. And so we want people to take them if we think it's right for them. So there are many of you, you're probably thinking, this is great, you know, talk to my healthcare provider and I'll talk to my caregiver, my friends and family, and we'll make a decision. This is great. Why doesn't everybody do that? Well, this slide highlights different barriers to why people aren't able to implement shared decision-making. One of the number one concerns is it's a practice barrier. So the hospital is busy. My doctor's too busy. My nurse is too busy. There's not enough time during the patient encounter. I have 5 minutes with them. How am I going to talk to them about what's important to me is what a lot of the patients say. The nurses and doctors might not also think that they make a difference. A patient barrier might be that the patient is hesitant to speak up. For many reasons, the literature has shown that people are afraid to contradict or question their healthcare team for various reasons. There might be a difference in goals between the patient and caregiver as well. Maybe the patient doesn't want treatment at all, and maybe the caregiver wants to recommend it, especially in that smoldering phase, right before there's active myeloma. There can be a lot of fears to when to start treatment, or if there's a relapse going on, is it really now should I be changing treatment, or can I stay on this treatment a little while longer? Institutional barriers might be the hospital itself. Again, maybe there's a lack of policy or time commitment on behalf of the hospital. And then so on. The scope of practice and the administration barrier really aren't as relevant to patients. There are in some states some laws and guidelines prohibiting people from actually autonomously practicing, and that would be perhaps the nurse practitioner or a physician assistant might be critical in driving your care, but maybe they're not able to provide a lot of recommendation. So patients can help overcome many of the barriers to shared decision-making just by being organized. One of the strategies that I recommend is to make a list of questions and priorities in advance of an office visit. There are tools and mechanisms in many centers. So for example, I have an electronic medical record and I let my patient email me or send me updates. You know, I have these 3 things I want to talk about next week when I come in. Is that okay? And then they'll show me what they are, so we're all prepared for the visit. Maybe they don't email it, but it can be written out on a piece of paper. Charise, are there any recommendations that you share with your patients to help overcome some of these barriers we talked about?
Now, I would agree that bringing questions are so important, because how many times, as a patient, have you gone to that visit, gotten home and said, oh my gosh, I forgot to ask them this, or you're there with us and it's like, I had a question and I can't remember. So I also recommend that you write them down. I've got patients who make lists on their iPhone or iPad or their cell phone, or bring it, and I would recommend that you limit it. You wait a long time to see us. Hit the pertinent things. Maybe it's 5 questions. But I also have some questions who will email the day before that, here's my list of things that I want to discuss with you. And that's helpful. I'm ready when I go to see them, and I think they get more out of the visit coming prepared that way.
Yeah, I think it's just more effective. So if I have 15 or 20 minutes per patient, it makes me so happy to know that they've put some time and thought into what's important to them, and then sharing it with me. It just makes the visit go that much more smoothly.
Yep, I agree. And so, and that's a good segue into the next section about writing down your questions in advance. And so, we're talking a lot about changing therapy or having those options at the start and at relapse, but there are also times, because you're having side effects, that we might choose to change therapy. So talking about those treatment options throughout, we know our patients are educated. That we, treatment changes, and you want to know what's that next thing, that plan. What are the pros and cons of these options? For some of you, is there dex involved, right? So we want to talk about those side effects, how it's going to be delivered. Is it a pill? Is it IV? Are you going to have to come into our center and see us multiple times? The insurance issues, the financial issues that are involved. And is this treatment a good option for you? You come to us sometimes. I just came from the support group meeting. I know somebody else who has the same type of myeloma, and their treatment's totally different. And, as you know, there are many types of myeloma, and even when it sounds like you have the same type, sometimes there are better treatment options per patient. It can be very individualized. So you want to let us know up front, right, from the start. I want to be part of the decision making, because, we talk about this, but these visits can get quick, and sometimes, we're focusing on here's what the numbers are doing, but we really need to take the time to talk about what's going on with you. Is this the best treatment choice for me? Is this the best option? And that caregiver, spouse, family member wants to know that we're also choosing the best option for their loved one, right? You need to ask us for time if you need it. Sometimes, there's just a lot to think about. And, we said earlier, the decision may not always be made in that visit. We have to give you the information, and sometimes you need to go home and think about it, talk about it, read the literature that we give you. If it's a clinical trial, to read over that consent, so you can really feel like you're making that right choice. Now, when is that time that we don't feel like we have all those choices? If we're in a situation where this is a aggressive relapse, that may be different. It may be today we need to add something different or switch, and, we're going to tell you that. And I think you need to not worry about upsetting us, right? This is your life, and these decisions and these treatments impact you. So how about the caregiver as well? We want to bring that caregiver into this decision making. When you're looking, there are so many resources out there, and throughout your treatment, you're wanting to know what's the latest, what's out there. I can't say enough about the IMS website. The information is there. They have people that can talk to you, but also your team, right? We want you to reach out to us if you're having issues, if your goals are changing, if this isn't working for you. We need to talk about that as well. And your goals and preferences are very important. I saw a patient this week who struggling with the current therapy, And he said, I know it may be working, but I can't continue on this particular therapy any longer. So we needed to listen to him. This is our patient. He's telling us we need to make a change. And so we sat down and we came up with options. What can we do? What's going to be better? What are these side effects? So we need to know that top priority for you, right? And if this isn't working or if we're not hearing you, you need to let us know that. So we'll give you choices when we can and see what you think and try to align that treatment with your goals and priorities, and we arrive at that decision together. And I think that's the important piece. And sometimes you're seeing the physician, sometimes it's the advanced practice, the physician is involved in these decisions, and we come to it together. And if we don't think that you're making the right choice based on what we've given you, we still might express that I think this is a better option for you. But at the end of the day, it is up to you, and you shouldn't feel talked into something. You should feel part of this decision and on board with it. So we talk a lot about patient-centered care, and I know for Beth, for myself, that's the model that we follow. Our cancer centers follow this. And you think about you as the patient in the middle of everything that we do. And the role of the nurse is very important in your care as well, in developing that relationship. We think of our nurses as the advocate. You might see one of us at the start of a treatment, but if you're coming into our center, getting something IV, you might be in the infusion center, we count on those nurses to assess and monitor side effects. Or if you're calling in and talking to one of our nurses, very important for us to hear you on that. Oops, I think we skipped ahead. So thinking about your nurse being a patient advocate, coordinating that multidisciplinary team. Have we made sure that we've let you know about those other resources that we have available to you? A nutrition team, supportive oncology, maybe pain management, getting those other resources in there. And a lot of times it's that nurse that's coordinating this care. There's a Shumer approach that I think is important to mention, and this is more geared to the providers, right? Because we're talking about this to the patient that you need to talk to us and let us know, but we also need to educate the providers how important it is to bring your patient into the conversation. So this is 5 steps that acronym SHARE from the Agency for Healthcare Research and Quality, and something that they're looking at is how do we improve the patient and provider outcome, right? So this is really more geared to that provider seeking to have their patient's participation and helping their patient explore and compare treatment options, not being rushed, knowing that we need to discuss all the options through from the start, assessing values and preferences so we can bring that into the best plan for our patient, and reaching a decision together, and then evaluating that decision, right? That next visit, how are you doing? Are you having side effects? So it's good for us all to be on the same page. And there are no decision aids for myeloma yet, as Beth said, and the plan is to work on these so we have more tools, because this is an important resource to be used in that shared decision-making process for both patients and caregivers. So we're going to talk a little bit now and go through a couple cases. And for this particular one, this is an example of a typical thing that we would see in one of our clinics. This is a 46-year-old female single mother who was initially diagnosed with her myeloma in 2008. And at that time, she was enrolled on a clinical trial with a proteasome inhibitor and an IMiD, achieving a complete response, and then was on maintenance until 2009. She didn't have a transplant at that point, right? Because even though typically now we do recommend those transplants up front, it's a conversation with your team, because sometimes that doesn't work in that lifestyle. And for this particular patient, that didn't work. She had 2 children that are both now in middle school. So when her disease became active, you've heard that term biochemical disease progression. What does that discussion sound like for us? And, when you have a biochemical relapse, you're starting to see movement in those myeloma numbers, but you don't see those end organ damage, that CRAB criteria coming back. So it's really important that we're monitoring closely and we're looking for symptoms at that point. So we don't always have to change therapy right away. But again, this is a discussion that we're having with our patient about what is our plan when we need to change treatment, how long are we going to watch this, and part of that conversation. And Beth, this is pretty common in our world. How do you handle this with your patient?
Yeah, Charise, I think this is, despite this being a 46-year-old case study, you know, this individual was young when she was diagnosed, and now it's quite a few years later, but again, her needs might be quite different from other needs. Somebody might be a 68-year-old grandmother or grandfather, or maybe there are no caregivers around. Maybe it's just you out there trying to navigate how to do it. So, but going back to this case study, some of the discussion that I have is things that we've talked about throughout. So I would say that Margaret's probably quite educated at this point on her diagnosis. She might be overwhelmed with her responsibilities of caring for her kids and shuffling them back and forth to practice. But I would hope that she would have identified a caregiver. Now that can be a formal caregiver or an informal one. A formal one would be maybe a boyfriend or a sibling or a parent, or it can be an informal one, maybe somebody from her place of worship or a work, because I'm guessing she might have some kind of work responsibility. So some of the things and how the conversation would go if she came into my clinic would be, you know, asking her, how is she feeling? Are there any new symptoms of back or bone pain? I would further ask her if she knows what her labs are, because oftentimes we get them in advance of the visit, and has she checked on, because a lot of these electronic medical records, you can see them online, and knowing that she had myeloma for a while, she might be savvy enough to look into her labs ahead of time. And then we kind of go through that discussion. What is biochemical disease progression? Like Charise said, we're seeing movement in the proteins. And then she would often say to us, well, what does that mean for me? Does that mean my treatment's not working? And so then I would encourage her to say, you know, these are the kind of therapies. What have you heard about the therapies that are out there? And is there something that you would like to think? Because, right, Charise, when we're following these people, it's not like all of a sudden we didn't have to treat you yesterday, but then now we do have to treat you. It's kind of a gradual. So you have those discussions of what would be the next step if I need to have treatment again. So that's the value of communicating with your healthcare team, is that you're kind of prepared before you go into those office visits. Just as we discussed early on, writing down on a piece of paper your concerns is important. I wanted to direct you, there's this yellow pop-up on this slide if you're online, and it talks about not only a new diagnosis of myeloma can be overwhelming, but treatment options. So following the 10 steps to better care, that's on the myeloma website, is an amazing resource for you. So even though the Myeloma Foundation has not necessarily termed the word shared decision-making before, they've been recommending tenets of it, such as being educated, using your voice, for years. Wouldn't you say, Charise?
No, I would, and there are so many wonderful resources there. You're right, and I'd also like to add, in this situation, this is, with this particular case study, this is why we ask you to do your labs in advance. I know sometimes that's inconvenient, and some people drive a long way and they can't, but so we actually have something to talk about at that visit. And so we're planning each time, even if we're not changing treatment or starting something, if you've been off treatment, we're making that plan. We're looking at how fast is this number changing, and it's so important.
Yeah, absolutely. Is there anything else you'd like to add to this case study before we move on to the next case study about how the discussion would go in your clinic? I think we probably practice very similarly. We try to encourage you to be prepared coming in as best as possible. That's not always possible, but the other thing is that not everybody will have somebody with them. We like a second set of ears. It's just not always possible. So I always encourage them to say we can have a phone discussion follow-up regarding the different therapies. Think of Margaret, who's only had one trial and not a transplant. So now we're talking maybe she would get a transplant, and what would her next therapy be? So we might want to continue this discussion over the phone, or depending on how far away she lives, bring her and a caregiver or a friend or somebody back with her as an extra set of ears. Wouldn't you agree, Charise?
No, I totally agree with that. And yeah, I think we can go ahead and move on to the next study.
Great. So William is a 77-year-old. He is a married, retired store owner, and he was diagnosed with multiple myeloma in 2015. He had been married for 52 years, and his wife was in generally good health at the time they were diagnosed. And he was treated with a standard therapy, which was an IMiD drug and our favorite, dexamethasone, continuously. But then he was not able to receive a transplant because he had high blood pressure. He did achieve a complete response, so most of the paraprotein that was in his blood was gone. His wife now, however, is showing early signs of dementia, and his priorities are changing. He's worried about insurance, and the costs of care are increasing. How should this discussion go? If William is now having a change in his priorities, most of us would be asking our patients to come back and forth about on a monthly basis. Sometimes we go to every 3 months, but generally more often labs. So if he's in a good remission, then we have to have that discussion. What are the concerns that you have? Is it financial, avoiding the co-payments for your medications? And in that case, maybe the nurse or the doctor or the healthcare team can relay them to some co-pay assistance foundations if that's a possibility for him. Maybe he needs to take a treatment holiday for a short term if he's in a complete remission and he's been in remission for a couple of years, sharing with him the data that continuous treatment is preferred based on the clinical trials, but we understand if it's a little bit overwhelming right now. Charise, do you ever see kind of instances like this where priorities change and then you have to have discussions about what to do next?
Yeah, we do, because, sometimes the patient becomes the caregiver, right? And, it does change. And so, we have to get, this would be a good case to get our social worker involved, in listening to our patient about their needs. And, are they at a place that they could have a treatment holiday? Can we get them to an oral agent so they don't have to come to the center so frequently? Do they have a local physician that could partner with us, to check those interim labs and those kind of things? And then, calling and checking on them.
Right, right. And we did talk, too, about special circumstances. Now, not everybody is going to have a caregiver. So Charise had highlighted the importance of a multidisciplinary team before, and that's really important to remember. No matter where you're treated in the United States or abroad, you typically will have access in one way or another to resources such as a social worker, another nurse. Now, it might be a treatment nurse. Maybe the individual's coming in for a weekly therapy, and you don't see the doctor or the nurse practitioner or the physician assistant all the time, the provider, but you might form a relationship with that treating nurse. Especially, I see that in the community all the time. So really identifying somebody you can talk to at that outpatient center that can be your partner. So it's not somebody who's necessarily going to come in and get your laundry or groceries, but it's somebody that can provide some resources for you in addition to the provider as well, especially if there's not a caregiver. Joining support groups like the International Myeloma Foundation, they do a phenomenal job, not only virtual support groups, but in person, and really forming those relationships. And I see it in my own area. People will come and bring soup if they're not feeling well, or they'll just pick up the phone and call just to see how you're doing. And I think that's important to form those relationships and know that you're not the only one who's going through this. Another special circumstance that can occur is when the patient and the family do not agree on treatment. A lot of times it's just they have different perspectives, and it tends to be a lot of times the really educated folks that have gone through the data and they say, no, you need a transplant, and the other one says, no, I just want to go on this therapy because it looks so good. So in that situation, it's kind of like the nurse and the oftentimes physician and the patient, the caregiver, in that shared decision-making dyad we kind of try to play a referee role and find out, why does this caregiver really want that patient to take that treatment? But we also want to hear from the patient. Charise, do you ever have any instances where people don't agree within the family or caregiver unit on what the patient should take, and how do you address that?
Yeah, we do see that. And again, it's talking through and trying to understand what they like or don't like about something that we're suggesting. And sometimes it could be because they're seeing what's going on with the patient at home, right? You come to the office, and how many times do we hear the caregiver say, they're telling you they're fine, but that's not what it's like at home, right? We're seeing side effects and other issues coming up, and so sometimes that's part of it, that they don't want to treat
a lot of
because they see that. Yep.
Exactly. So discussing the concerns and the pros and the cons of different treatments can help arrive at different decisions.
Yes.
So important decisions for patients with myeloma. This is all kind of a little bit I don't want to spend too much time on this slide. We talked earlier about critical periods in which decision making is necessary, but remember, it's not just with treatment. It's not just with us saying you might be better off with radiation or surgery to control your pain, or bone strengtheners such as bisphosphonates to control your bone disease. It might be things like, do you want to have treatment on a Monday or a Friday? I think we all try to do this, but inviting people in to make that decision. Just because we scheduled you for a Monday infusion doesn't mean you have to adhere to that schedule if on Mondays you pick up your grandkids from school. So making sure that we know what your needs and wants and what's important to you are out there is just as important with treatment as in the office visits and adjusting medications such as for blood pressure and etc.
So I think additional strategies for communicating with the team, again, it's letting us know what's important to you. Are there those important events, graduation, vacations, if those family get-togethers that you're worried about going because you're going to miss your treatment? We need to work with you on that, to have those drug holidays. Letting you know what's the latest data out there, what are those newer therapies that we're seeing good results with. There are so many clinical trials, so many things right now coming down the pike that we're working on. It's hard for us to keep up, so it's hard for our patients. So it's up to us to talk to you about that. How about things that have changed in your life? Are you having issues getting your medicines or having transportation issues? We need you to tell us about those things that have changed. So we might need to make adjustments. You were able to afford the drug and now you can't. How can we help you with those things? And I can't say enough about don't be afraid to ask questions. Also, sometimes you have to seek another opinion. Beth and I both work in a myeloma center, but nobody knows everything, right? And again, you're establishing that relationship with your patient. You need to be confident in your providers. And if you ask your healthcare team, let them know that you do want to go somewhere else to have another opinion, they should be okay with that. You don't want to have somebody that you're afraid to have that conversation with, right? And sometimes it can be helpful to have other healthcare providers weigh in on your decision.
I agree, Charise, and that's one of the things we hear a lot is that people are just afraid to seek that second opinion. And I just want to encourage all of you, and I think the IMS encourages all of you to be your own advocate. And if something doesn't feel right, even if you have a wonderful relationship with that provider and that healthcare team, it's okay to say, my sister lives in Tennessee, can I go there and seek a second opinion, because maybe then I could be close to them and visit, and there's a lot of reasons, and it's okay to do so.
Absolutely. And it's not a big community, right? Myeloma, we know each other, right? And so we can help you with that. Or if you're moving, there are lots of options. And even with our best efforts, things happen. And we're always trying to make our centers better, to make sure we get your phone calls and we communicate with you. And, we're working on that, but, sometimes it just may be that you're more comfortable with another provider. So at the conclusion, with all the available treatment options for myeloma, we know these discussions are more important than ever, and we have to have them with you. And here are the options, here are those side effects, and it's okay to ask your team to discuss these treatments with you. You should know why you're on antivirals. You should know about bone strengtheners. How often do you need Zometa or Iridia? Have we put you on these things? And we need to be explaining why we're starting you. Are we starting you on an aspirin because you're on an IMiD? And you want to consider this shared decision-making approach to find out how it works best for you. What's the best way for you to communicate with your team, and what works for your family and caregivers as well. But at the end of all of this, remember that you are your own best advocate. You know, we're doing that for you too. The nurses are doing that, but it's you and that caregiver that really are looking out for you. So we are so happy you joined us today, and I would just like to also thank the IMF and thank Beth. It's always a pleasure to join Beth on these things. And so now we are happy to take questions.
Okay, thank you, ladies, for these helpful strategies to share decision-making and case studies to really illustrate some successful communication between patients and caregivers and our healthcare providers. I'm sure this is going to help us to have much more productive conversations with our healthcare team. So we now will move on to the question and answer portion of our webinar. And to just remind anyone, and also those that have recently dialed in, if you have a question for Beth or Charise, please remember to type it into the control panel under questions. And just a reminder that we ask questions to be general in nature and specific to myeloma to benefit all the listeners on this webinar. And I also see that we've got a few support groups that are actually participating on this live webinar right from their meetings tonight. So that's fantastic. Wow. And a great way to gather and to learn. So please write in your questions as well. And so we've got quite a few questions tonight, but we will stay on the live call for at least 10-15 minutes so we can get to as many of these as possible. And so Beth, the first question here is for you, and it comes in from John. And first he says, thank you, this was a great presentation, both Beth and Charise. And are there any resources that I can look forward to sharing with my loved one? Beth?
Yes, so Robin, thank you for that question. So there are so many resources. So I did mention, as did Charise a couple of times, the 10 steps to better care. So again, even though we are just, it's hot off the presses, this shared decision-making in myeloma, value-based care is more important than ever in the last few years, and really finding value. But the 10 steps to better care, the International Myeloma Foundation has been doing it for years. So look at the 10 steps for better care, and without using those shared decision-making words, there are integrated ideas in there. Also, the Agency for Healthcare Research and Quality was listed on one of our slides, and Charise presented that piece. And they've been, since 2005, putting forth information as well as some of the other big academic centers. So there's just a plethora of information, but hopefully you'll be able to re-review back through some of this presentation and find important hints for your caregivers to find more information about the treatment and what's right for you.
Excellent. So I've got another really important question from Gail. And Gail's got some thoughts about who exactly is, when we talk about our healthcare team, does that also include social workers? Because she's asking questions about financial assistance and difficulties in, affording care and what the resources are out there. So are there social workers part of this team that we should be reaching out to?
Yes. I would say, you're going to find that for sure at the academic centers. We have a few more resources, but I think in a lot of the oncology, the community oncology practices as well. And I think that's a really good question, and it's good to know what are those resources that are available to you from the start, from the first time. At our center, our social worker tries to meet with every patient the first time they come. Sometimes it can be a little overwhelming because you meet so many people, but we do like to get our social worker involved from the start. You can ask to see the social worker at any time. I think if you've identified that there's some new a financial issue or some other issue, we certainly bring our social workers in on a regular basis.
Yeah, and can I further add to that, Charise? We have, in a lot of centers, you have nurse navigators. So I have wonderful, wonderful social workers that we work with, but sometimes it's as easy as saying you have a $50 copayment for each specialty office visit and you have Medicare. Now we have Medicare open enrollment. Perhaps you should investigate your state's plan to decrease copay costs. So sometimes a social worker isn't even necessary. It can be just from the doctor or the nurse that works in the office as part of the team that can help guide you to the right ways or lead you to the Leukemia and Lymphoma Society's page or the American Cancer Society's pages as well.
Mm-hmm. And I'll just add too, you know, we do throw that term around healthcare team, and there are so many parts, right? I mean, we haven't even mentioned our clinical pharmacists who are part of our team as well, and nutrition support, and there are just so many people that we consider all part of that team that you get when you see us.
Right, and maybe you don't, for the shared decision-making aspect of it, maybe you feel more comfortable talking to a social worker about your concerns versus the doctor or nurse because you don't want to make them offended or sad or disappoint them if you're not taking your medication. So think of the social worker, the pharmacist, the doctors, nurses, infusion people as all part of your healthcare team.
Yep.
Okay, thank you. And so now we have a question from Joel, and he really was interested in the discussion on second opinions, which really in the myeloma world is so important, as we all know. And so Joel is wondering about how do we find the most appropriate person for a second opinion. And I think that for me, I've always gone to the International Myeloma Foundation, called their info line at 1-800-452-2873. And I know that they have a list by state of who the myeloma specialists are and then their contact information. So if you are looking for a myeloma specialist second opinion, or even a myeloma specialist in your area, you can call the IMF info line. And then we do have another question for Charise just came in. This patient is concerned. My doctor recommends that I have a bone marrow transplant, and I'm not sure if this is what I want, but they're adamant that this is what should be done for me, but I'm afraid to say no. So what should I do?
Yeah, that's a good question. And, you know, clearly it sounds like there needs to be further discussion. So, you know, typically for a patient who is transplant eligible, most centers are going to recommend that induction therapy followed by a transplant. But we have to listen to our patient and their needs. So, you know, is there a reason that you're not interested in transplant? Has it not been explained to you? Are there just social reasons? This is not something that you can do in your life right now. And, you know, sometimes we have to decide that, okay, we're going to continue on, you know, finish out induction, continue on a maintenance type therapy and watch those numbers and then go to transplant at first progression. I think it's important for both parties to get together and discuss it. Are there high-risk factors that the physician is worried about that is pushing more that you've got to have this transplant now? And, you know, sometimes that's the case if we see a more aggressive type myeloma. But, again, at the end of the day, this is your decision, and your healthcare team is going to give you their best advice. But you have to make that decision together, and sometimes the right thing for patients is to delay transplant.
Yeah, and Charise, might I just add, it's not only transplant, sometimes you have to have those discussions, it's change in therapy. So throughout the discussion today, we highlighted there's different pill therapies, there's IV-based therapies. So taking just a piece of paper with your caregiver, writing down what's important to you, and sharing that with your healthcare team, I think will be one of the most valuable things you can do, in addition to getting your labs in advance in preparation for your office visits whenever you can.
Okay, so we do have another question, and this may be the last question, but again, it's an important one. Ladies, you mentioned something about writing a plan, and this patient is wondering, should we or when will the Nurse Leadership Board have can we expect a written plan for our cancer journey with goals for survivorship? Is that something that NLB is working on?
Yeah, so what I wanted to comment on that is that each year there are 20 of us nurse leaders, and we convene in a location and we decide on projects for the next year. And our next biggest initiative, I hope I'm not blowing the stack or giving away secrets, but our next big initiative is really focusing on 2018 to 2019, all of our efforts towards the shared decision-making idea. How do you really enact the shared decision-making model? Can we reach how many patients and give them the tools that they need to make their own decisions, such as patient calculators, to plug in the information, what's right to you, and this and that. So anyhow, so that's in the next calendar year, we're all getting together and we're doing tip sheets and pull-out sheets, etc. And so I can't give you a time and when these would be available, but as they come out, we're going to put things hopefully on the website so that you could access them and be a little bit more informed on the process and learn more strategies about finding what's right for you and your caregivers, etc.
Okay, so Beth and Charise, I want to add to that too, because I know that the nurses just had a publication in the Clinical Journal of Nursing Oncology, and the IMF printed out patient education tip sheets, and these are available through the IMF, and they're really very informative tip sheets on everything from peripheral neuropathy, renal, GI, distress, fatigue, even sexuality, and many other topics. So again, I'd like to
thank depression, don't forget.
Yes, yeah, absolutely. All these important topics. So I think I want to just let everybody know that any questions that they didn't have answered tonight, we do have, of course, the IMF info line is always available to you. Missy, Paul, and Judy are happy to take your calls. They are available Monday through Friday, 9 to 4 Pacific. Again, the number is 1-800-452-CURE, which is 2873. And so I'd like to thank Beth and Charise for creating this excellent presentation and taking the time to answer our questions this evening. Shared decision-making is key in working closely with our healthcare team to ensure we're all striving toward the same goals. So a few reminders tonight. The IMF website is a wealth of information, and that's www.myeloma.org. And also a replay of this webinar will be available early next week, and you can access this webinar and all previous IMF webinars at myeloma.org and just click on IMF TV. And just a couple of important reminders. The holidays are right around the corner. And did you know that you can support the IMF just by shopping? Simply go to amazon.myeloma.org, and a portion of your purchase will be donated by Amazon right to the IMF. So that's a great, easy way for us to support myeloma. And then another important announcement is ASH. The American Society of Hematology meetings are December 8 through 12. The IMF will be there in force with interviews from myeloma specialists, satellite symposium with doctors discussing diagnosis, treatment approaches, strategies, future options. The IMF will also have a broadcast of the International Myeloma Working Group's conference series, providing a point and counterpoint discussion and review on the myeloma trials presented at ASH. And in addition to all of this, if that wasn't enough, the IMF will once again bring a group of support group leaders to ASH to share their patient caregiver perspective with you through blogs and tweets and also on the IMF website. So please make sure to mark your calendars and check the site daily for all this really, really important information that's going to help us all. So once again, thank you so much to our speakers, Dr. Beth Faiman and Ms. Charise Gleason. You both were wonderful. I really enjoyed everything that you brought up today. And to our sponsors for making this happen, thank you so much, Amgen, Celgene, Janssen Oncology, and Takeda Oncology. And most importantly, thanks to all our participants on this call. We're so glad that you were able to join us, and we hope you found this helpful. I hope you all have a wonderful evening. Thanks, everyone. Good night.